I don't. I'm not fast to make any prejudgments or any statements on whether something will be I think it's obvious with the classified documents is by looking at a photo of a secret documents in boxes not secret that there's something wrong and that never gets tried. I think the whole presidential immunity thing is just it doesn't matter how many scholars set out.
Good afternoon. Did y'all think you got rid of me? Well, I thought I got rid of you. No. Yes, thank you. So last semester, how exciting. Part of it is women's health. May not be that exciting for some of y'all, but every 2 hours that you spend with me, 2 hours closer to getting the heck out of here, right? So we'll make do. So I am happy to see you guys, and welcome to your senior semester. You got my email on here, you got my phone number, same as when I taught you guys the occasions. If you have anything, please reach out. Don't wait till the last minute before the exam. If there's something you're not getting, you gotta know that now, because you will see women. Okay? No matter what part of the military you're gonna be in, you're going to see women, because we have women in all the areas or aspects of the military. One of the things I want to say is, I think, if you don't remember, I'm primarily emergency medicine. So I've been in emergency medicine PA for 20 years. Looked at BMC and a bunch of rural areas around here. And one thing that there's lots of things I love about emergency medicine, intubating people and saving people's lives and calling code STEMI, and then the cardiologist come down and listen to a lot of good things. But there's very, very few shifts that I walk out of, even after being a PA for 30 plus years, that I don't learn something. Maybe it's something about a patient, maybe it's something about medicine, and I can carry on to the next patient, but there's very few shifts. And so you guys may go into your phase 2 and be really, really super smart, right? Okay. But if you think that you're so smart you can't learn anything else, that's probably not the right attitude. You've got to go in saying, yeah, I think I know what's going on here. Of course, here's my differential, and be able to learn from every single patient. And again, sometimes it's really just pulling up that chair next to the patient and spending that extra 5-10 minutes talking to the patient and trying to explain to the patient what you believe is going on and the reason why you believe that's the case. Because nowadays we really, most of the time when people get sued, is because that patient left not satisfied, and it's not primarily because no one took the time to explain to them what was going on, even if you can't fix them, right? So we have huge influenza A outbreak now. So we're just seeing tons and tons of influenza A. And patients feel crappy. I saw a young kid yesterday. He came in. He had been sick for 4 hours. So a troopy here. Oh, he's got tears in his eyes and sneezing and carrying on, right? He's like, I'm just so sick. I'm so sick. And so sick that I can not even really hear him talk. And I said, no, I've got 500 other patients to see in the waiting room. I'm going to need you to move things along a little bit here. I'm going to need you to tell me exactly what's going on. And at the end of that, I said to him, I said, I didn't mean to be rude. You are telling me about your grandparents and your toes and all these things. We got to move things along. And when he came back, guess what he had? He had influenza A. So I brought him back in. I said, well, this is why you feel so crappy. And this is probably why you can't, speak very loudly. So I'm sorry that you don't feel well, but I'm going to help you feel better. And here's what we're going to do, right? So although I was a little gruff, because we see a lot of troopies, in the end, you take them back in and you talk to them and tell them what's going on, what they can do to make themselves better. Most of these guys, most people you see, they don't take any medication. Well, did you take anything for your fever? No, I wanted to come in and make sure you knew I had a fever. So you didn't take anything. Did you take anything for your cough? No, I didn't take anything, I didn't want to take anything. But then you came to me. So patients can be frustrated. They can be frustrated. Spend the time, get the frustration out of your brain, spend the time with that patient to explain what's going on and how you're gonna help them. Okay? And as much as you don't want to say it, before they leave, say you're always welcome to schedule another appointment with me if you need to be seen again. I put it on every single ED discharge, and as much as I don't want to do that most of the time, I do it. Right? I do it because I'd rather them come back than sit at home. So maybe 2 months ago, we had a droopy troopy that came in, and they're gonna put him in the fast track so he can get seen real quick. The PA that saw him was like, this dude is sick. Like sick, like he can't even hold his head up. But the thing is sometimes people are a little bit dramatic, and so she was giving, saying like, well, okay, well maybe that's the case. That kid, she quickly realized he wasn't dramatic and moved him somewhere else. He was altered within an hour of getting in a bed. He ended up having an intracranial hemorrhage, meningitis, encephalitis, and died. He died. 19 years old. 19 years old. So we've got to take the time, and this wasn't, his vital signs, guess what? They looked great. Until they didn't. Until he became altered and needed. So we've got to take the time to evaluate these patients and know that we're not always going to be right? Am I an expert at OBGYN? I'm a lot better now than I was, I'll tell you that. Okay? Am I an expert at emergency medicine? No, but I feel like I'm pretty good at emergency medicine. I'm not an expert at ENT, I'm not an expert at ortho, but you become well-rounded, and that's the best kind of PA that you can be, is a well-rounded one. Yes, you're gonna miss things, we all have missed things. It's the nature of practicing medicine. But if you have your differential and you create your differential and you have a wide net for these patients, you'll have a lot less failure. And you'll walk out of those days when you're in the ER or those days that you're in clinic and say, one, didn't kill anybody today, okay? And two, I actually feel like I helped people. Okay? You can't fix the flu. What can you give somebody for the flu? Tylenol, ibuprofen, Mucinex, cough medicine. You can't fix it. But you can give your patient realistic expectations. Look, you're gonna feel pretty darn crappy for the next 3 days. Okay? That is just the way, it doesn't matter what you do, you're gonna feel crappy. After that, then we expect. If you tell that patient, come back and see me in a couple of days if you're not better, they're coming back because they're not gonna be better in 2 days. Okay? Give them realistic expectations and give them follow-ups. Okay? But that's not women's health, that's just being a person, being a PA. Okay? Again, there's varying degrees of interest in women's health in this room. 0, probably there's some people that are really, really interested in women's health, that's okay. But we teach this to everybody because it's not a matter of if you're going to see a patient with vaginal discharge or a pregnant patient that is deployed and having vaginal bleeding. It's just a matter of when you're going to see them and making sure you have the tools to be able to take care of these patients. A couple things, just kind of some housekeeping things. So we got to make sure that we are all here to learn. I'm here to facilitate you learning. So again, if you have any issues, if you feel like you don't get a good concept of something, then let me know. Okay? We have realistic expectations. We'll go by the syllabus. We have typically I'll do not using in-person exam review, but oftentimes I'll send out something to kind of help you guys hone down what you need to focus on. And I typically show up on time. I'm not here 30 minutes beforehand, but I'm usually here about 5 minutes beforehand. So if you have any questions, you can do that before class or even after class, or text me or email me. I never intend to go over my 50 minutes. I forgot to start my time. But if I do, just raise your hand and say, hey, quiet, you need to take a break, all right, and then we'll stop and we'll take a break. topics. I never intend to go over that 50 minutes. We have 50 minutes of lecture per 1 hour, and we take that 10-minute break. Remember that when you leave here, you are not PAs. When you leave here, you're going to hospital-based training. Our job here in phase 1 is to prepare you for that hospital-based training. When you're in your hospital-based training, you're going to work with a lot of different preceptors that do things oftentimes a little bit different. That's a part of learning medicine. You don't want to learn from the same person all the time. So when you leave here, you may not feel like you're prepared to see patients. None of us felt like that. But ultimately, you will be. You'll have the clinical knowledge, okay, the book knowledge, and then you're going to go there and you're going to get the hands-on knowledge that you need to go along with this book knowledge. By the time you get done with phase 2, that's when things are going to be different. That's when this book knowledge needs to meet that physical, the hands-on knowledge, and ultimately for you to pass not only PA school, but to pass your PANCE, because you have to pass your national residency to be certified. We've got 40 hours of lecture. We have 3 exams. We will have 1 lab, which is a really basic lab, and then you have an RTA lab, and that's run by Clinical Skills, so Mr. Fuchs runs that. And that's where you're going to actually do physical exams on patients. You're going to do breast exams, pelvic exams, and then you'll do testicular and prostate exams for those. So that's going to be your probably N of 1. You have hands-on experience, and then you get the rest of that in phase 2. All I need you guys to do is show up. Okay? It's not my job to police y'all. If you're sleeping, I guess you're tired. Like, I can't help it. You guys have long days. I think most of the time you guys record these lectures. I would just tell you that if a PD walks in and y'all are taking a big old snooze, you're probably gonna be mad. I'm a contractor, I don't get mad as long as they pay me, right? So just try to police yourselves, and otherwise we'll do just fine. We don't teach to the NCCPA blueprint. However, what is the PANCE based on the NCCPA blueprint? So the most recent iteration of PANCE is 7% reproductive health for females, and it's going to be on the PANCE. So we've got to know these. And these are all the different topics we cover. So it's not just women's health. Because can a female be a female and have abdominal pain that's not related to a women's health issue? Do all females have abdominal pain? Do they all have gonorrhea, chlamydia, or ovarian cysts? No, they can have things like appendicitis, just like a male can. Okay, can they have a rash that is not related to a female issue? Absolutely. So, and then pregnant patients. Can a pregnant patient come in with an ankle sprain or appendicitis or cholecystitis? Absolutely. So you can't compartmentalize women's health as just women's health. Okay, it's the entire patient that you're evaluating. So on the PANCE, you will be giving a scenario maybe with a pregnant patient. Now it's up to you to pick out what they're asking. Maybe it has nothing to do with the pregnancy at all. So you have to prepare for that. As we go through these classes, I do want you guys to focus on things like health maintenance, patient education and prevention. We are such a reactive society and not a proactive society. We won't become proactive unless people like you make it a proactive situation, right? So we want to do that. And we do that not because it's just part of us being a PA, but it's really a part of a broader system. We call it systems-based practice. The best thing I can ever do for a patient is educate that patient on what's going on with them. We've got our TLOs, and then our ELOs. Today is a pretty quick lecture. We're going to go over anatomy, okay? And we're going to do a little bit of embryology, just so you can understand where a female comes from. But this majority of this should be reviewed from the freshman semester. We're going to start off with this little vignette. We've got a 19-year-old female is coming in with primary amenorrhea. So primary amenorrhea means really they haven't started their menstrual cycle, usually by the age of 15 or within 5 years of signs of puberty. So primary amenorrhea says that she has been sexually active for the last year, said the same partner, but she does say that he reports kind of some resistance with penetration, and she does have some pain with penetration. They also, post-penetration, post-intercourse, she has some vaginal spotting. Past medical history, medications, all of that is unremarkable to include no significant family history. On exam, looks like a normal female action pubic hair distribution. Breast development is Tanner stage 5, so have you guys learned Tanner stages yet? Pete? So normal breast development, okay? And normal female external genitalia. Okay? Anything else you want in this patient? Maybe some labs. Maybe some labs. Maybe she's come with primary amenorrhea. The number one cause really for secondary amenorrhea, but could also be primary, is pregnancy. She's having intercourse and she's pregnant. So let's get some labs on this patient. ECG. Think about thyroid. So thyroid presents in all sorts of different ways. Okay? If I have patients that come in and they're just kind of all over the place, oftentimes I'll do a TSH on them. LH, FSH, what are we looking, where is that coming from? LH and FSH come from the pituitary. Then you have progesterone and estrogen that comes from the ovaries. Here we have prolactin, that comes from. Okay. And then talk about maybe some free or total testosterone, depending on what we're seeing on physical exam, right? But all of that stuff is normal. HCG is negative. Okay? So then we have to think about other things. Okay? We want to know, when did she start thelarchy? So thelarchy is breast development. Okay? When did that start? So 12 years old. Pubarchy is development of the pubic hair. That's at 13 years old. Does that sound in your mind kind of normalish?
Yes.
It is. So we typically expect puberty to start around 10 and a half to 11 years old. Okay. That related breast bud development. So all of that sounds okay. What is your differentials for this patient who has, looks like normal labs, normal physical exam, okay, at least externally normal physical exam from what we know. Any differentials? Anything that would make her not have a menstrual cycle, but otherwise appear like a normal female?
She had the XY testosterone.
Yeah, she could have some sort of embryologic abnormality, right? Some sort of congenital abnormality. Yeah, sure.
Well, what's her BMI? Like, how big is she? Because if she's skinny, she may have lost it.
Things like what?
Like if she's anorexic or very, very thin, she may have lost her period.
Right, so something like excessive weight loss, excessive weight gain, if they're super athletic, then that can delay their onset of menstrual cycle. PCOS can do that. Okay, imperfect hymen, so they could be having menstruation, but they don't have any way for the blood to get out because they don't have a hole in their hymen. Hypopit, okay, they could have scarring for some reason in their uterus, or get an outflow tract problem. So we've got to create our differentials. And then from those differentials, because we could have thyroid on there, but we already said the thyroid is normal, but that would be as part of your initial differential, which would warrant you to get that thyroid. So we've got to create those differentials. That's a pretty good difference. We'll talk about this patient more at the end and see what your differentials are then. All right, so anatomy of the external female genitalia. We're going to make sure we use our grown-up words, not only because it's important in class, but it's important really when you're talking to your consultants, right? When you speak to your consultants in phase 2, you've got to know what words to use to properly describe a female internal and external genitalia. So we've got our perineum. The perineum is housed, it's kind of this diamond-shaped structure. And we've got the pubic symphysis on top, and then we've got our coccyx that's on the bottom portion of the perineum. The perineal boundaries, okay, really we have two diamond-shaped structures within that large diamond shape. Okay? We have our urogenital triangle, which is located on top, and that is a pubic symphysis on top of it, and is surrounded by the issue tuberosities. We've got our anal triangle, the posterior triangle. We still have our issue tuberosities. We have the coccyx at the bottom. And then in between those two triangles, we have the perineal body. And that's just kind of this fibromuscular junction that separates the anterior and the posterior triangle. Of course, we've got the anal sphincter that's also in the posterior triangle. And then we've got a lot of different muscles. The main portion of our muscles is going to be the lever ani and the coccygeus muscles. And the primary portion of those is going to be located in the posterior triangle. Those are really important muscles because as a person gets older, they gain weight, they have babies, that musculature tends to get weaker and weaker, just a part of existing. And then what happens with that, then our pelvic organs are not supported very well, and then our pelvic organs can collapse. We also want to think about maybe some obstetric complications that can occur within the perineum. Okay? The anterior urogenital triangle is very, very vascular, okay? Especially during pregnancy when we have increased estrogen. Every time you have increase in estrogen, increases vascularity. And when you have decrease in estrogen, it decreases that vascularity. So patients that are pregnant, they can have excessive bleeding postpartum. They can have lacerations during delivery, lacerations of the vulva, lacerations of the cervix, and that can cause bleeding. They can have hematomas that develop. They can even develop vulvar varicosity, so like hemorrhoids, only in the vulvar area, vulvar varicosities. And then that perinatal body, that fibrous membrane, that can be compromised during childbirth as well. If you have a big baby, they have a difficult time getting that baby out, they may cut it. We call that an episiotomy. If they don't cut it, mom may tear. They can have significant tears. Tears can be so significant that they'll go all the way down into the anal triangle and down and cut through the rectum mucosa. So we've got different degrees of tears that can occur. And then, again, anytime a patient is pregnant, the more times they are pregnant, we've got that musculature that will ultimately get weaker and weaker with each pregnancy, just because the increased pressure that those pregnancies place on the pelvic musculature. Other structures that we can see in the perineum. We have our mons pubis, which is up on top, and the pubic mound. We have our labia majora and the labia minora. Remember, the labia minora is on the inside, the labia majora is on the outside. And we also have things like the clitoris. Okay, the clitoris is going to be anterior to the vaginal opening. That's something called the vestibule. Now the vestibule is Latin word for door, and it runs kind of in the interior portion near where the hymen is. It's not the hymen itself, but it's a tissue on the outside of the hymen. We've got our urethra that is located in the anterior genital triangle, and alongside the urethra are something called the Skene's glands. And the Skene's glands lubricate the urethral opening. We have Bartholin's glands as well, and those are located at the forward incline position, just below on the outside of the vagina. So labia majora, sex differentiation, if you remember, doesn't occur really till, 5 weeks, 7 weeks or so, 10 to 12 weeks if we're looking for ovarian development. So you're going to have some homologs to male and female structures. So the labia majora, there's a homolog to the male scrotum, and the appearance kind of changes with age, changes with pregnancy, it really changes with a person's health status as well. Okay? They essentially merge overlying the perineal body, so they merge in the middle. At puberty, they're covered with hair, and then they have this apigram, exocrine, and sebaceous glands. And again, these are very, very vascular. So patients that are pregnant, increased risk of swelling, increased risk of varicosity associated with that increase in estrogen and increased vascularity. The labia minor, that's homolog to the ventral shaft of the penis. And that's a different type of tissue that we're going to see on the labia majora. Okay? Here it is more sensitive. It has different types of glands in there. It does not have the hair that we're going to see on the labia majora. Okay? It fuses superiorly to form the prepuce of the clitoris, and it can also vary in appearance from younger to older, decreased estrogen to increased estrogen in pregnancy status. There's this thing called the heart line, and that heart line is kind of the mucous membrane between the labia majora and then the skin. External to that heart line, we have keratinized tissue. And then internal to that, we have non-keratinized tissue. And that's important because that non-keratinized tissue has this consistent, people don't like to use it, it's consistently moist, right? And so it has that lubrication. By it continuing to stay moist, it helps prevent bacteria from getting into the vagina. It helps protect the vagina and the vaginal opening. You will find that during the RTA lab, people's appearance differs. So usually what I recommend is, you gotta use your inside voice when we're doing our physical exams. And, we gotta have a patient laying down, they're gonna have a drape over top of them. And when you're doing your exam, you may find something or see something that looks a little strange, keep it inside. Because it's real. Remember, you are under the covers, you can just be like, and don't say one word. I was seeing a patient that had Bartholin's abscess. And I was like, okay, like I've seen many times. I numb them up and go to cut, and the only thing went, and the patient had no idea. The patient had no idea. The nurse was like, and I was like, and I just was like, oh my God, so I'm done. And I'm just like, oh my God, this is so bad. And I get down like, everything went great? Everything went great. Don't let them know. But, so when you're doing that, you guys will just have one patient that you're doing the exam on. You don't get to do a round robin exam for you have one male, one female. And so you'll see, and most of these females have pretty normal anatomy, so you probably won't see anything too scary. We've got the glands of the clitoris, that is the erectile tissue, and that's homology, the erectile tissue of the penis. Really the female erogenous zone, and it has the glands. It does have the corpus cavernosus, and it has these two crura, and those crura are on the alongside the clitoris, and they just kind of anchor the clitoris to the underlying bony structure. The clitoris itself is going to project downward and towards the vaginal introitus. You've got your mons pubis, and that is the pubic mound we're going to see at the inferior portion of the abdomen. And as a person goes into puberty, that's when they're going to start to develop hair in that area. Again, the vestibule, that's that door. That's a kind of a membranous embryonic derivative. And again, it's not the hymen, but the area between the heart line and the hymen. And it extends all the way up to the clitoral frenulum. And then it contains things like the urethra. You have the vagina in there, you have that Bartholin's, and you have those Skene's glands that are in there. Bartholin's glands, 4 in 8 o'clock position. They are subject to having cysts that develop in them or abscesses. And so that's why it's really important that you know that they're at the 4 to 8 o'clock position, because women have a lot of different glands in their perineum, and any of those can get cystine. So if you're seeing somebody that looks like they have a cyst or they have an enlargement and it's up more towards the 11 o'clock position or 1 o'clock, that's not a Bartholin's gland cyst. And they sometimes have to be managed differently. And depending on the age of that patient, that actually may be some sort of cancerous process, and you don't want to just willy-nilly IND something that you're not exactly sure what it is. Okay? Those patients may warrant actually referral to OBGYN before they get intervention. Skene's glands are those periurethral glands, and all their primary purpose is for lubricating the urethra. Hymen, that's that thin connective tissue in that vaginal introitus. And everybody, or most people, most women, have a small hole in their hymen. But the hole can really vary. Sometimes it's more of a, sometimes it's a single hole like we see here. Sometimes we have micro perforations like we see here, and sometimes like that. Okay, the whole intent for that, having at least a small hole, is for when patients start their menstrual cycle, there's somewhere for that menses to go. Okay? So if they don't have a small hole, they have something called an imperforate hymen. If they have an imperforate hymen, they may come in to you saying that, hey, I have not had my menstrual cycle. I'm 14 or 15 or 16 years old, no menstrual cycle. So you've got to then ask them about any cyclical symptoms. Say, like, are you having any sort of abdominal cramping? Maybe it's less than 3 or 4 days out of the month. Any sort of breast tenderness, any sort of headaches, or do you feel bloating or weight gains for certain parts of the month? And maybe that's your indication that this patient is having imperfect hymen, because oftentimes when we're seeing these young girls in the clinic, we want to do everything we can in our mind, at least, to not do a vaginal exam on them. We're like, oh my God, I'm just not really sure if I should do a vaginal exam. And so that is kind of a scary situation to be in, especially the first couple times you do it. So if you can get a good history that leads you to believe that that may be the cause of them not having a menstrual cycle, then that would warrant a physical exam after that. And what you may see on physical exam is you may actually see a kind of a blue tinge of that hymenal tissue. So you look into the vaginal torus, and you look in that, oh my gosh, yeah, in the vaginal torus, and you'll see, you don't have to put the speculum in, you can just spread the labia apart, and you'll be able to see it in there, and you can see kind of a blue tinge, and that's just old dry blood that's in there. And again, that may be your indication. Now, there's a lot of thoughts about how the hymen itself gets completely ruptured. So again, most people have a small hole, but for complete rupture, it could be really just insertion of a tampon. It could be injury to that area, a person riding their bike and they fell on the bar of the bike, or it could be typically from first intercourse. So that is it for external genitalia. So I told you a real brief overview of this. Now let's talk about our internal genitalia, vagina. We have a cervix, uterus, the fallopian tubes, and the ovaries. Okay, vagina and the vaginal introitus really is this muscular membranous tube that's going to extend from the hymenal ring all the way up to the uterus. The length is going to vary in size from female to female, but it is very vascular in all females. Even more vascular, of course, when we have increased estrogen, like in someone that's pregnant. Because it is medial to the heart line, it's made of a non-keratinized stratified squamous epithelium, and so it's more friable, it's less resistant to trauma. So you may have patients that come in who have aggressive intercourse, and they can have lacerations in the vaginal wall, vaginal vault, and they'll come in with pretty significant bleeding from that. It does have a smooth layer. There's also an adventitious layer that has elastin in it, and that just allows that tissue to be more pliable, allows it to stretch when needed, whether it's intercourse or penetration, or if someone's having a baby, it allows that tissue to stretch. The vaginal tissue itself really doesn't have any glands, and so the lubrication that it gets is a transudate lubrication. During pregnancy, then we can expect that these patients may have on a daily basis a lot more vaginal discharge, just because they have an increase in estrogen, increase that transudate, and increases the secretion. The other thing we think about with the vaginal tissue, because it is so estrogen sensitive, as a patient ages, they're going to have a lot less lubrication. So you may see patients that are in their 40s, late 30s, 40s that come in or start to complain of pain with intercourse or pain with penetration that they didn't have previously. Sometimes it's really just due to a decrease in estrogen. And so you need to know that that tissue is going to change. It's going to become more atrophied. It's going to become more friable. These patients will a lot of times have a lot of more irritation. They'll have more of a thin kind of discharge and more of a mucousy discharge. And the other thing we'll see is a loss of rugate. So instead of it being kind of up and down, we can see kind of, what's the word for it, besides rugate? Folds, kind of folds in there. Now it's going to be very, very smooth. And usually it's, because of the atrophy, it's not that bright pink. It's more of a pale appearing. And that's one of your indications that this is probably due to loss of estrogen. We've got our cervix. Cervix is a lower portion of our uterus. When you feel the cervix, it kind of feels like the end of your nose. I know that that's a weird analogy, but sometimes we have to have our patients do intravaginal medications, and we want them to put that medication right near their cervix, and the patient's going to be like, what does that feel like? How do I know I'm there? And you can tell them it feels like the end of your nose. Okay? So it's kind of, it's not super soft, it's not super hard, but you can definitely feel it when you feel it. The cervix really has two openings. You have an external os, and then you have an internal os. Which one do we see at exam? The external os. The internal os opens up into the uterus. Okay? And then there's other portions of the uterus. You've got the vaginalis, which is above on the upper portion of the cervix, and then you have your portion vaginis, which is the inferior portion. Depending on if the patient has been pregnant and delivered or not, or depending on what their cervix oftentimes looks like. If we think about a nulliparous pregnant or nulligravida, they have no prior pregnancy, no deliveries, they often have a small, round cervical os. A patient that has delivered or that has been pregnant, they often have like a slip like cervical os. Even patients that have had C-sections, okay, and they have not had a natural vaginal delivery, most of the time with a C-section, they will still have cervical changes, okay, because of the increased estrogen. And sometimes the OBGYN will actually go in and do kind of a manual dilation, which helps, which even helps with the delivery, the C-section delivery, so that can change, but usually it's hormonal related. So sometimes you'll see a little bit change, but then when they do the vaginal delivery, you'll definitely see this more slip up. And when you do your RTA examinations, that would be something that I would recommend looking at. You should be able to see the difference in that cervical os. On the outside of the cervical os, or the cervix, we have squamous, squamous epithelium. And then the inside, we have columnar epithelium. As a patient ages, just as a product of aging, that columnar epithelium is going to become more outward, and it's going to start pushing that stratified squamous epithelium out. And what happens when you have change in where cells meet is cancer. So it's that transformation zone. That transformation zone is what the area that we take when we take our pap swab and our cervical cytology. That's what we send off to the lab for evaluation to evaluate for cervical cancer. That's another thing that you can often see on these patients when we do the RTA. You can see that change, that transformation zone is often really obvious in the majority of these patients. Alongside the cervix, we have 4 fornices, or recessed areas. You have one on both sides, you have one on the top, and one on the bottom. Most of the time nowadays, even the clinics have ultrasound. But one of the really important things about checking for these fornices is you're going to feel to see if you feel any masses, okay, on those sides. The other thing on that, especially that posterior fornix, that retrouterine area, if someone comes in, let's say they have abdominal pain, they're pregnant, they haven't had an ultrasound yet, they're hypotense, it might be an indication that they have an ectopic. And then when you do your exam, that retrouterine area behind the cervix, you can actually see a bulging of the thing called the pouch of Douglas, because that's the distalmost portion of the abdomen, so you'll actually see that in the physical exam. So when you're doing and checking these fornices, you got the cervix in the middle. Usually for your bimanual, you're going to just take 2 fingers. You're going to have one hand on the top of the abdomen and 2 fingers inside the vagina. You're just going to go on both sides of the cervix. You're going to go underneath the cervix, and you're going to go on top. And it also helps you identify if that cervix is fixed. Usually the cervix is a little bit mobile in a normal person. Things that can cause the cervix to be fixed would be something like endometriosis. We have scar tissue around the cervix. We've got the uterus. It is a pear-shaped. And it varies in size from female to female, and of course if someone's had a baby or is currently pregnant versus someone that is nulligravida or not pregnant. Normally, if in a non-pregnant patient, the uterus is going to be about 6 to 8 centimeters, and it's going to lie between the bladder and the rectum. That cervix is going to be the lower portion of the uterus, and that's the internal os and then the external os. The isthmus, you can't really see a good picture here. I think the next slide is a better picture. But the isthmus is typically right in here, and it really joins the main portion of the cervix, or the corpus, or main portion of the uterus, which is the corpus, down to the cervix. The top portion of the uterus is called the fundus. It's important to know that because we feel for the fundus on physical exam. When we do our bimanual exam, we're taking our hand again on, one hand is on the outside of the abdomen, we're pushing down to try to feel that fundus to make sure we don't feel anything abnormal in the fundus. When a patient is pregnant, we use the fundal height to help us identify how pregnant they are as well. So it's important on physical exam to understand where that fundus is going to be. The posterior wall of the uterus, the upper portion, the fundus, Why is that important? What happens there? Hopefully implantation. Hopefully implantation. Because if we can get that baby to implant on the upper portion of that fundus, then that gives plenty of room for the placenta to grow. So further down that baby implants, more likely is that placenta is going to overlap the cervical os, and that can create significant problems in pregnancy and certainly pushes these patients to have a C-section. The uterus is designed to house a person, so the musculature of the uterus is super strong. We've got 3 layers of mushroom, the peritoneum, the myometrium, and then we have the endometrium. The main part of it we talk about is the myometrium, and the muscles associated with the myometrium, they're actually interlaced, which allows for hemorrhage control in a postpartum situation. It also allows for stretching as the baby gets bigger and bigger and bigger throughout the pregnancy. And then we know already about the endometrium, the lining of the uterus. The lining of the uterus is designed to slough off every month, so about every 28 days. The patient has a menstrual cycle, and that's a sloughing off of the endometrium. And that's really considered a functional layer of the uterus. Of course, if mom gets pregnant, then that's going to be the area that the implantation is in that endometrium. The way that the uterus is positioned in females can be different as well. We know that it's a pear-shaped. We know that it can vary in size, but how it's positioned in in females, it can differ as well. Most commonly, we're going to see this called anteroverted, which I have circled here, that is anteroverted. You could have a mid-plane uterus, where it kind of goes directly in. And then you can have a retroverted uterus, which kind of going more towards the rectal area. The other thing that can happen is just the fundus, just the top part of the uterus, could be abnormally shaped. We refer that more to a flexion. So a flexion could be anteroflexion, or it could be retroflexion. So anteflexion or retroflexion. So if we think about the uterus itself, we're going to think about verted. If we think about the fundus is going to flex anteriorly or it can flex posteriorly. So here in Bravo, we have a anteflexed uterus. So just the top part of the uterus, just the fundus, is kind of flexed up. And how do you think that will affect your physical exam? Would it make it easier to feel the fundus, you think, or harder? Much easier, right? It's like, oh, wow, there it is. But usually, if it's anteverted, we can feel it. Mid-plane sometimes, usually retroverted, we typically can't feel the fundus. At least not on abdominal, when you have your hand on the abdominal exam. So yes, we have those different, the different ways that the uterus can look. So here we have anteroversion. Okay, we've got anteflexion here, or again, we just have the fundus that is flexed anteriorly. And then here we have retroflexion, just the fundus. So we still have the main portion, the distal portion of the uterus. When we put our speculum in right here, we'll be able to see that cervical os. We're just not going to be able to feel the uterus, at least not on the abdominal exam. Now, if you have a patient like this who is retroverted and retroflexed, how is that going to change your exam? It's going to be hard. It's really hard to find the cervix in some of these patients. So sometimes these patients know, and they'll tell you, oh yeah, my cervix is super hard to find, and they say it's blah, blah, blah. Like, okay, if they say it's retroverted, you've got to go in with that speculum way down. You got to come all way down, and then pull it up, okay? So usually anteroverted, you're going directly straight in, and maybe up a little bit. Mid-plane, you're going straight in. When you have retroverted, you're going down, and then you're going to try to pop that cervix up above, in between your speculum. So make sure exam's super hard. And it's impossible to feel the fundus of the uterus this way. For patients like this, you actually have to do a rectal exam to feel the fundus of the uterus, because it lies right on the rectum. So then again, think about these patients that get pregnant. if they have a retroverted or retroflex uterus, and the complications they're gonna have. They're gonna have complications with not only using the bathroom, but a lot of times they have significant pain in their SI joint areas because of the amount of pressure. It's changing where the pressure points are gonna be for these patients. So your uterine position certainly has physical exam implications, and you need to be aware of that. And the uterus is going to change in size based on the age of the patient. So we've got a neonatal uterus here, we've got a 4-year uterus, okay? And we also have puberty, we've got adults that has never had a baby, we have adult that has had a baby, and then we've got the postmenopausal patient. So we know that neonatal uterus is going to be a little bit larger than we have a 4-year-old baby because of mom, right? Because mom's hormones are still in the baby, so the uterus is going to be a little bit larger. Again, as we get older, decreased estrogen, the uterus is going to get smaller and smaller in size. We've got fallopian tubes. Those are the muscular tubes that are connected to the uterus. They are open at the end, right? They have fimbriae, okay? And are they connected to the ovary or not? No, they are not connected to the ovary. So the ovary will release an egg, and those fimbriae reach out, grab the egg, and then pull it up into that with this sweeping motion. What happens if someone has had a surgical removal of a fallopian tube? And what if that ovary is still in place and that ovary releases a follicle? What happens? Just gets degenerated? The tube from the other side reaches over, grabs it, can sweep it in. There's not that much space in between the tubes, right? So that tube actually can make a sweeping motion and pull that follicle that was released over to it, and it can sweep up that follicle into the other fallopian tube. So patients can still get pregnant even if they've had what we call a salpingectomy, which is a fallopian tube removal. The fallopian tube has different components. So we've got the ampulla. It's important to know that because it is the most common site of fertilization, which also makes it the most common site of an ectopic pregnancy. Ectopics can occur anywhere, but most commonly it's going to be in the ampulla. Ideally, what happens is you have fertilization in the ampulla, and then through the movement of that fallopian tube, it continues to move it on into the uterus, up in the posterior fundal wall where it implants. We've got ovaries. So ovaries are super, super small, about the size of an almond. Most women have 2 ovaries, okay? And the size of those ovaries are going to change throughout a female's lifespan. Okay? A little bit smaller before menarche, before they go to puberty. And then reproductive ages are going to be a little bit larger, and then as they go into menopause, they're a little bit smaller. And certainly, these are releasing estrogen and progesterone throughout their life. So when you have increase in estrogen and progesterone, you have a little bit larger, but they're not very big in general, which means that they're typically not palpable on physical exam. If you can palpate an ovary, that's usually something pathologic with that ovary. There's something going on with the ovary. So even in very, very thin patients, ovaries are not typically palpable. So some patients will say, or some students will say, well, then why do we do bimanual exams on patients? It's a good question. There's actually a lot of literature out now that says, maybe we don't, maybe we shouldn't, okay? I know at AMC, if females come in, they're complaining of vaginal discharge, we no longer do pelvic exams on the majority of those patients. They go to the bathroom, they swab themselves, and we send that off. So pelvic exams and bimanual exams are kind of up in the air right now for at least in the emergency department setting, even in the primary care setting for the most part. The only thing that my argument for that is, I want to see in 15 years from now, how much cervical cancer we're missing, or how much vaginal cancer we're missing, how many STIs are going untreated because we're not doing examination. You can certainly have a person swab and send it off and they tell you an STI, but we're not, it's really nice to be able to physically see that you don't see anything, right? People put things in the vagina and they don't often admit to it. So they kind of come with a discharge and their swab is negative. So I don't know, that's just kind of the way things are going right now. It's been like that for like the last for almost 3 years. So we'll see what the future brings. But you still, when you go to phase 2, I would recommend you do as many GYN exams as possible in the event that you're going to be doing those outside of phase 2. All right, let's go ahead and take a break and then we'll continue. Blood supply and the outer layer of the ovary is the epithelium. Now, every month that a woman ovulates, she breaks the outer layer of the ovary. So the ovary outer layer essentially opens up, the follicle goes out, and then it heals back up, which increases a female's chances of ovulating more of ovarian cancer, because again, we have disruption of the cell. So we will talk specifically about ovarian cancer in a different lecture, but the patients that are pregnant more times than those that are not, if every time you're pregnant, you're not ovulating, right? So they have a decreased chance in ovarian cancer. Medications like birth control pills. Birth control pills work by preventing ovulation. So birth control pills actually can be protective against ovarian cancer. We've got our musculoskeletal component of the pelvic anatomy. And there's a couple of terms you gotta be familiar with. There's a false pelvis and there's a true pelvis. The false pelvis kind of upper portion or up north, and then the true pelvis, that false pelvis is gonna physically support a growing baby. You've got the true pelvis, that's more down south, and that's the passageway for which the fetus comes through. So true, we tend to think like childbearing, and then false is that supporting structure as a baby grows. Up to about 12 weeks. Once your baby is about 12 weeks, then it grows outside of that maternal pelvis, and they don't have a lot of supporting structure at all. So if mom gets in a fender bender car accident beyond 12 weeks, they don't have that bony structure of the pelvis to support and protect the baby. Now, the important thing about that true pelvis is baby's head. So baby's head and baby's head position. So if mom is lucky, baby's head is going to be tucked nice and tight, like a paratrooper, of course. Right? And nice, and chin is nice and tight in there, and that reduces the biparietal diameter. So in other words, we got the least amount of head space going through the maternal pelvis. If baby is coming out like this, okay, looking around, but it increases the biparietal diameter, so from here to here coming out of the maternal pelvis, by about 2 to 2.5 centimeters. So that's significant when mom's already trying to squeeze the baby out. And then there are different types of pelvic shapes. So we have gynecoid, and that's the most favorable for vaginal delivery. We have anthropoid, that's more over elongated, and that is okay for vaginal delivery. Android and platypuloid. So android, we think about like Martians. Platypuloid, we think about a platypus, they lay eggs, not babies. So those are not favorable. Those are not favorable at all for vaginal delivery. So gynecoid is the most favorable. If we have to do it with the anthropoid, we can, but what we don't want is android and platypuloid. We don't have so much of a problem nowadays with pelvic, the musculature of the female pelvis. But we think many years ago we had things like rickets, or even nowadays some kind of car accident, and they had a pelvic fracture that could have implications on whether they can or cannot have a vaginal delivery. So gynecoid is going to be your most favorable. You've got to know where the vasculature is located in the stomach as well, right? Because some of these patients will get C-section deliveries. And if they do an incision too high, it is likely that they can run into the vasculature and cut these very large vessels. The deep vasculature and the superficial vasculature, they come off of the femoral and the iliac vessels, so they've got a lot of pressure. So when you cut through them, you're gonna know it pretty darn quickly. Okay. So initially, you've got the vessels that kind of come towards the umbilicus, and then they start running superiorly. There are different types of incisions that they use for the C-section, but the most common incision that we're going to use is something called a phanastile, so it's a much lower kind of the suprapubic area. Actually, Lieutenant Phanastile, he was here in OBC like, gosh, maybe 12 months ago or something, and his grandfather created the phanastile, or great-grandfather, I guess, created the phanastile incision. We used to do a little bit higher. So when I trained, the C-section was a little bit, incision was a little bit higher, and now it's a little lower because it reduces the chance of running into those vessels. The other thing we do for our incisions on the abdomen is we want to think about things called the Langer's lines. You guys learn about the Langer's lines yet? Not, you learn about those in dermatology. So you guys hopefully will be in positions that you can cut off lots of things from people. But every time you cut them off, you want to go in association with those tension lines or Langer's line. So for females that are having C-sections, we go horizontally because that's kind of where the Langer's lines are. And it reduces the amount of tension. If you were to do a vertical incision through the tension lines, then you have much higher likelihood of that incision not healing well. Ooh, what's that? So you have a much higher likelihood because of an increased tension on that incision or on that wound of it not healing well. We also have nerves. We have nerves that run not too far away from even where that phanastile incision is at. And one of those nerves is the iliohypogastric nerve. It's the most common nerve that if a nerve is injured, it's going to be that nerve. Those patients will come in with numbness, so maybe 3 months or so after they have a C-section, they'll come in complaining of numbness. That's over like the lateral glute area or the lower abdominal area. So if they're coming to you and they say, yeah, I had a C-section, and I just thought this numbness was from the C-section because they told me sometimes I can have that, but man, it's still there, that's indication that iliohypogastric nerve was probably transected and or injured, and they may never get that feeling back. So I would say, maybe you should go back and see your OBGYN doctor who did your incision, and then come back and see me, because you don't want to get involved in that, right? You want to be up on the stand where they're asking you questions about that. But in general, sometimes complications do occur, and for you guys, you might see those post-operative complications from something like a C-section. Even something like appendectomy, sometimes that can occur as well. All right, so we think about sex differentiation. We think about where does all this come from? Where does female come from? Where does male come from? So we know that about 5 weeks, the embryo is going to begin the sex differentiation process. Before 5 weeks in utero, sex is undifferentiated. So about 5 weeks it's going to start. It's kind of committed for males at 7 weeks when the testes start to develop. And then we have ovarian development about 10 to 12 weeks when that occurs. And sex differentiation occurs because of the absence or presence of what? A Y chromosome. It has nothing to do with an X chromosome. It's the absence or presence of a Y chromosome only. So if we have a Y chromosome, you can follow this down here. If you have a Y chromosome, we're going to have something called testes determining factor. Okay, that's pretty self-explanatory. It determines that the person's going to have testes. Okay, but what it also does is it puts out what we call Mullerian inhibiting factor. Mullerian structures are the female reproductive structures. So we're going to have Mullerian inhibiting factor that then prevents female structures from developing. Instead, you're going to have testosterone that develops. You're going to have growth of the seminal vesicles, okay, the vas deferens, and then ultimately you're going to have a fusion of the radiosacral folds into valves. If we do not have a Y chromosome, If we do not have a Y chromosome, we don't have testes determinant factor. And instead of this Mullerian inhibiting factor being suppressed, it is now going to be present. So we're not going to have that. We're going to have Mullerian structures that develop. Those are the female reproductive structures, but they're specific female reproductive structures. Okay, we're going to have the fallopian tubes, the uterus, and the upper portion of the vagina, the upper 1 to 2/3 of the vagina. That is what's going to develop from these germ cells. So we don't have Y chromosome, that means we don't have testes determinant factor, and then ultimately the female structures are going to develop. Initially though, we have both female and male ducts. Okay, so here you can predominantly see male ducts. Here you can see female ducts that are starting to play, have a role. And here you've got female ducts that are becoming more prominent. When we look down here, we must have the absence of that Y chromosome, because what we can see here is we can see the beginning of the regression of those male structures. We've got our Mullerian ducts that are taking hold, and the female structures are starting to develop. Here we have near complete regression of those male structures as well. And then the kidneys and the ovaries, those are developed from other structures, not specifically from the Mullerian ducts, or other ducts that develop those. And then ultimately, bless you, ultimately we only have our female ducts that are associated with, again, development of the uterus, fallopian tubes, and upper third of the vagina. So ovarian development, we're going to think about that as histologically, we can identify about 10 weeks, but really we won't see those ovaries till about 12 weeks. We have something called gonadal cords, and those are just precursors, ovarian precursors. They develop into ovarian follicles. At about 16 weeks or so in utero, we have primordial follicles that develop. We've got those oocytes. And then around that, we have the follicular cells. And that's where the word follicle stimulating hormone actually comes from, because, and that's we see that at puberty primarily, and that's released from the anterior pituitary, from the pituitary gland, that stimulates the follicles in those hormones, or in the ovaries to develop. So before birth, you have millions and millions and millions, upwards of 15 to 20 million follicles. At birth, that means if a person could, they could have 20 million babies, okay? If each one of those follicles develop. Thank God they don't, right? So at birth, though, we have 2 million follicles. So females have about 2 million follicles at birth. All of those, again, can't develop into babies. Many of them degenerate, they regress, and they go in. We only have one primordial follicle each menstrual cycle that has a potential patient getting pregnant. You have multiple follicles that are developed, but only one that goes to full development and has a potential fertilization. So all the eggs a female has, they're going to have before birth. And they don't produce any eggs postnatally. No eggs postnatally. So people talk about, well, because you think about your mom, right, before she was born, so your mom actually has your grandbabies in them, right? Because you have your eggs before you were even born. I think it's interesting. You guys are like, All right, so if we don't have a Y chromosome, okay, there's no testes determining factor, we have no Mullerian inhibiting factor, okay, the Mullerian ducts are present, so we're going to have the female reproductive organs. And that's where I think the Mullerian ducts, the fallopian tubes, uterus, and then the upper portion of the vagina. And then the ovaries in the lower portion of the vagina, again, they have different embryologic origin. So you could have someone that comes in and you do an exam on them and you can put the speculum in and they clearly have a vaginal opening and still not have Mullerian structures that develop, right? Because this is the upper portion of the vagina, not the lower portion. Now, they may have amenorrhea, okay? They may have, that'd be your primary thing, is amenorrhea. That may be your only insight to, hey, like, why are they having amenorrhea? I can clearly see a vaginal vault, but what you won't typically see, okay, is the cervix, because that vaginal vault is going to end in a blind pouch. It's not gonna connect with the uterus. Okay, it's gonna, because that structure, the distal portion of the vagina comes from a different ducts, not from the Mullerian ducts. Okay. So at 5 to 7 weeks, we got the formation of those Mullerian ducts, we got the regression of the Wolffian ducts, and then we're gonna have those two ducts that are gonna fuse, and that is what becomes our uterus and then our upper portion of the vagina, the fallopian tubes. We have complete reabsorption by about 20 weeks in utero. So initially you have two ducts, okay? Eventually those two ducts are going to kind of fuse together, okay? That's gonna give our reproductive structures, and then we have this, all we have left remaining is this, what we call this septum, and then most people at about 20, most women at about 20 weeks, this septum is gonna be reabsorbed. There are people that have a intrauterine septum. It does not reabsorb, and they actually can get surgery or have surgery to remove that septum so they can have increased chance of childbearing successfully. So we have anomalies, of course, that can result. So not everything goes as the textbook wants. Not everyone develops like the textbook. Females can have issues with the development of, or the normal progression or the normal regression of those reproductive structures for a variety of reasons. We can have incomplete fusion of the two Mullerian ducts. We can have incomplete canalization. Okay? And we can have the fact that we have, people can have, you have incomplete fusion, people can come in with have two vaginas. You can have two uteruses, and that's because the ducts didn't fuse and create one set of reproductive structures. So again, not very often, but it certainly can occur. So if we have incomplete fusion, if we do have two ducts that don't fuse at all, we can have two uteruses. Okay, uterus didelphys is what this is called. Now those two uteruses could also have two vaginas. Okay, sometimes you'll have two uteruses and one vagina. So it can occur in a variety of ways. Usually, only one uterus is actually capable of reproduction, normally. Not always. There are always case reports, right? Where patients can get pregnant, they've gotten pregnant in both uteruses. But normally, that's not the case. You can have something called a bicornuate uterus, where just the superior portion of the uterus is duplicated. This can hinder, sometimes can hinder reproduction, but oftentimes these patients can get pregnant, but there are increased risk of miscarriage with these patients. You can have a bicornuate uterus with a rudimentary horn, meaning one duct didn't try so hard, right? One duct did not develop well. The other duct did okay. But now we have this kind of smaller portion of the uterus. You can have that septate uterus, okay, that goes, like I did where the inside did not completely regress. And that essentially separates the uterus into two parts. And again, surgery can make go in there and ultimately do that if it's identified. Usually identified in ultrasound. Oftentimes this will be someone that maybe comes in complaining of something like infertility. And trying to get pregnant, can't get pregnant. As part of the workup, they may identify this person as a septate uterus. Okay, and then you can have a unicornuate uterus where one of the paramesonephric ducts failed to develop. So paramesonephric, we relate that to females. Mesonephric, we relate that to males. Okay. So mesonephric and Wolffian males, paramesonephric and Mullerian, that's females. Okay. That brings us to something else we may see that's associated with sometimes congenital anomalies or anomalies associated with these mesonephric and paramesonephric duct development. Okay, so sometimes those Wolffian and those Mullerian ducts don't completely regress. Sometimes you have continuation of the Wolffian ducts and the Mullerian structure, so male and female structures. Okay. And this can cause anatomic abnormalities. Sometimes you can have chromosomal abnormalities in these patients. that can cause some abnormalities as well. So we think about things like Turner syndrome, which you guys probably learned in endocrine, I assume. Okay? And probably in endocrine, they told you should know about Turner syndrome because there's always a board question on Turner syndrome. So 45XO. That's going to be a chromosomal disorder of sexual development. You can have something like 46XX, okay? And here, these patients have both ovaries and testicular tissue, so they are often not able to reproduce. So again, infertility, or they're not able to even have evidence of puberty. So Turner syndrome, we think about Turner syndrome as primary hypogonadism. So primary hypogonadism means we have problems where? At the gonads, right? Primary hypogonadism, okay? And this is in females, they're 45XO. And so we're going to see on labs, okay? You're going to see on labs, hypergonadotropic hypogonadism. So hypergonadotrophic. What does that mean? But what does it mean for us lab-wise? So we have hypergonadotropic, we're talking about FSH and LH, right? Those are going to be elevated because the problem is at the gonads. And we're going to have constant bombardment of FSH and LH from the pituitary to the gonads because they're trying to get the gonads to work. They don't know. They're like, why am I not getting a negative feedback to shut down? So I'm going to keep bombarding them to make them work. But the problem is they cannot work because it's a primary hypogonadism problem. So whether it's be the testes or the ovary, but the problem is there. Okay? It's not with the pituitary. It's not, when we think about HPO axis, it's not the hypothalamus, it's not the pituitary, but it's in fact at the ovaries themselves. So these patients typically have low estrogen because it's a gonadal, it's a problem with the ovaries themselves. That's that short stature. It's that webbed neck appearance. Okay? If I was a betting person, I would know these lab abnormalities. You don't have to know numbers, but you gotta know if you're ordering these labs, what it means. If I got somebody there at elevated FSH and LH and a low estrogen, I need to know that. I don't know what that means. Okay? So again, we have these streak gonads, meaning the gonads are just really, really poorly functioning or non-functioning. So they may have a little bit of estrogen that's kicking out, but not very much. And of course, they usually have a very obvious physical stature, but they also may come in with delayed breast development, delayed menarche, so not having a menstrual cycle. We've got to do evaluation with those hormone labs. We'll do genetic testing. Typically, this is done not necessarily where you're at for active duty, but for National Guard and Reserve, you guys may be working in a pediatric clinic somewhere, so this may be your responsibility to work these patients out. For these patients, they will often treat them with something like a growth hormone, okay, and then they will typically give an estrogen or progesterone, and that kind of helps them more go into puberty where normally they wouldn't. We've got Kallman's syndrome, is also it's a sex disorder, and this can be male or female. These patients typically have something very unique. They can't smell anything, so no, it's not COVID, but usually they're born that way, they can't smell anything. And it's a problem actually at the, do you guys know where the problem is with the patient? The hypothalamus. It's actually at the hypothalamus. So GnRH. So we have a lack of GnRH, and if you don't have GnRH, that's not going to go down to the pituitary. It's not going to go down to the ovaries. So these patients have hypogonadotropic hypogonadism. So hypogonadotropic means that our FSH and LH are going to be low. Low. Our estrogen is also going to be low because the problem is GnRH. GnRH is not getting down to the pituitary to tell the pituitary to stimulate the pituitary. It's not getting down to the ovaries. We don't have stimulation there. Again, normal for these patients, oftentimes for Coleman, they'll come in with infertility, especially males. They come in with infertility. They look normal. They have normal sexual differentiation most of the time. So they look like a normal appearing male, but they're coming in for infertility. Okay? For females, sometimes they have poorly defined sexual characteristics. They don't have good breast development. Oftentimes they're coming in for TCU because of amenorrhea. They're not having a menstrual cycle. They never have had a menstrual cycle. Again, if you can tease out from these patients, and most of the time the mom or dad would just say, yeah, I don't know, they never been able to smell very well. But that isn't, that's usually something you can just kind of ask these patients. Most patients don't talk about the fact that they mess up. They just don't really think much of it, because maybe, maybe they had someone in their family that couldn't smell. So we're gonna check this now. We're gonna check the hormone labs on these patients. That includes the LH, FSH, and the estrogen. So estradiol is a strong estrogen. Think about that GnRH level as well, maybe even prolactin level. Ultimately, they may need to bring an MRI, and usually we'll start to do genetic testing in these patients. Treatment is hormone replacement. We do estrogen and progesterone for females. They can do GnRH injections as well, and that induces ovulation. And then HCG injections will help for these patients to increase their chance of fertility. So we've got 46XX. So here you have ovaries that are present, okay, and they're normal, but oftentimes these patients kind of have ambiguous genitalia. They can have both male and female structures that are present. Okay. For female, they're going to have more masculized or more male-appealing female genitalia. So we think about an enlarged clitoris on physical exam. Maybe they would have partial fusion of the labia. So I remember I had to do a lot of well baby checks when I was at Fort Bragg in primary care. So from 2 weeks on, we did those checks because the pediatric clinic was really inundated with pediatric patients. And I caught this a couple of times where they had the fusion of their labia, and so we sent them back. Sometimes it's not this. Babies, neonates can just have fusion of the labia and is treated with topical estrogen. But it's something you need to consider in these patients, and I would not hesitate to send them to pediatrics and say, hey, let them say that that's all this is, and let them manage you for now. Once they figure that out, then they can send it back to you. But if you see partial labial fusion, I would probably put a consult in for pediatrics. There's a lot of different causes, but the most common cause of this is going to be congenital adrenal hyperplasia. Where the baby is really just not producing, they're producing steroids, but it's not really the right amount of steroids. Sometimes it's too much, sometimes it's too little. So think about things like PCOS can cause this. Masculizing tumor, we have androgen excess, that can cause this. It can cause, again, that female to appear more male. All right, so let's go back to our case. We've got that 19-year-old female. She is sexually active. She's coming with amenorrhea. She had TRP at 12, TRP at 13. Labs looked okay. She is sexually active, but does say that she has pain with intercourse, and she's had a little bit of spotting after intercourse. Normal external female genitalia, normal axillary pubic hair development, and normal breast bud development. Otherwise, labs okay, med history okay, no family history. And then anything else. Do we want to do anything else for this patient? Should we do a physical exam besides rudimentary? Yep, look like you have, breast development, look like you have pubic hair. Anybody want to do a vaginal exam on this 19-year-old? What if the patient was 15? See? It's like, oh, man, I don't know. So it is a sticky situation. You've got to get the parents' permission. You've got to get the patient to understand the importance of it, and the parents. And you've got to get buy-in from the parents for this. If it's a situation where you, in phase 2, do no pediatric pelvic exams, this may warrant a pediatric consult. Okay? But I would at least entertain doing a digital exam on this patient. Talk to parents about maybe a digital exam on this patient. And again, if it's not something you're comfortable with or familiar with, then send this patient to pediatric for primary amenorrhea. She's never had a menstrual cycle, right? I mean, that is the number one reason to send these patients to pediatrics. So this patient's 19, depending on where you're working. This may be an adolescent clinic, maybe an adult clinic. For us, it's under the age of 22, goes to adolescence, and over the age of 22 is considered adult. Isn't that crazy? 22. 22, like our pediatric, they get admitted for peds, under the age of 22, they go to peds. So all the way up to 22, they go to peds. So just know where you're working at and what the parameters are. So I would say, you do your exam, and you any radiology studies you might want to get. Let's get an ultrasound. Yeah. Transabdominal or transvaginal? Probably can do a transabdominal, right? We're looking for things. We're looking for structures. They should be able to see that on your transabdominal ultrasound. And yeah, so in a patient that you're like, man, even if you're not comfortable doing the exam, okay, you can still order radiology studies. And I wouldn't order a bunch of radiation studies, but ultrasound is pretty easy to get. There's no damage to the patient, doesn't cause radiation. It's pretty unremarkable, and the patients tolerate it pretty well. So we can look for those structures. So this patient actually, they did a transabdominal ultrasound, and that transabdominal ultrasound showed, what do you think? What is your differential now? So can we still think PCOS? Maybe, right? We still see PCOS. Thyroid was normal, so that's off. Hymen, can we still think imperforate hymen? Maybe, if we didn't see any blue tinge there, maybe not. Gotta ask about cyclic symptoms. Are you having any sort of cyclic abdominal cramping or discomfort? Anytime that you have breast tenderness or pain, for a few days out of the month. If they don't have any of that, probably not that. But ultimately, this person that did karyotyping on, they had 46XS, they did an ultrasound, there was no uterus, no fallopian tubes. Okay? And so this person is not going to be able to have a menstrual cycle because they don't have the capability. So they have those Mullerian structures and Mullerian adenosis. Mayer-Rudzinski-Kuster-Hauser syndrome. And guess who caught it? A phase 2 student. A phase 2 student interviewed this patient, not this past summer, but the summer before, and emailed me and said, oh my gosh, guess what? Because I had actually had a different patient scenario that I talked to them about, that class about. And then they sent me this, I was like, oh, I can use that. Anybody that wants to go to Campbell? Anybody? Anybody going to Campbell? Nobody? Campbell is amazing. I can't even tell you the stuff that I learned at Campbell. I learned because there was no competition with residents. And I talked to quite a few of the PA students that are there now, and they're like, oh my gosh. So like for OB/GYN, I was first up. I slept in the cot in the OR, next to the OR, and they called me. Surgery, first up. I had the little back thing, a little beeper, and they paid me. I want to see the patient, and they got to call the surgeon. Like all of that we did on our own. There was no resident to compete with, there was no nothing. So you can learn as much as you want at Campbell. They have a really, really good program. Okay. But yeah, this person had Mayer-Rudzinski-Kuster-Hauser syndrome, and then ultimately she was having pain with intercourse because she had the distal 1/3 of her vagina that ended in a blind pouch. So she could still have intercourse, but the vaginal vault is not going to be very long, and so it's going to feel like there's a lot of resistance. It's going to be discomfort that's associated with that, and certainly some bleeding afterwards because of the irritation of the vaginal vault, because it ends in that blind pouch. And you can actually see that when you do post-hysterectomy exams. You'll look in there, I see a cervix. And everybody's, oh yeah, I had a hysterectomy. And they'll sew up the back of the vagina, And so it'll end in this, in that. So when you have patients that have hysterectomies, it's really, behooves you to do exams on them, so you'll see what that looks like. There's a whole bunch of tissue in the back of the vagina. All right. Okay, I think I see you guys next week. So have a good weekend. What do you have tomorrow?